Thank you once again. Very good afternoon. The case for presentation now is titled The Mercedes-Benz of the Orbit, and we shall still decipher it at the end of this presentation. I would thank my mentor and our ocular expert pathologist, Dr. Kaustubh, for giving us the most valuable inputs during this case. So what's the story for today? We have a middle-aged lady who presented with protrusion of the right eye since 3 months and diminution of vision in the right eye for distance and near for 6 weeks. And on our examination, we found a proptosis of 12 millimeters with a palpable mass in the superior temporal quadrant of the orbit, a dystopia of 3 millimeters, a positive pressure on retropulsion. More importantly, temporal fossa fullness, and it was negative for a bend valsalva, a thrill or a brewery ruling out a vascular lesion. This is a 9-gaze picture of the same patient showing restriction of ocular motility in all the gazes, and there was decrease in the corneal sensations and also the supraorbital sensation. Radiological evaluation to supplement our clinical acumen showed that there is an ill-defined mass in the intra and extracorneal space of the right orbit, where there is a breach and it involves the temporal fossa. And there is a focal erosion of the bony roof, and it is extending, even involving the zygomatic arch, but there is no intracranial involvement. With this, we clinico-radiologically think that this is a lesion which is centered at the sphenoid trigone. And what are the possible differentials with lesions centered on the sphenoid trigone could be: one is it can be a sphenoid wing meningioma, second is orbital plasmacytoma, osteosarcoma, orbital metastasis, and barring this age group, it would be a primary neuroendocrine tumor. So when in doubt, it is always best to think calmly, and then we proceed with a more definitive diagnosis. We went ahead with a biopsy via the superior subbrow transperiosteal approach, which is a multi-level incision biopsy to involve the epicenter of the lesion. And this is a pre- and post-operative photograph of the same patient. On biopsy, what we find are plasma cells. On immunohistochemistry, they were positive for the cluster differentiation 138 and negative for 23 and pan-cytokeratin. But is this the end of the road? Is just knowing that a plasma cell malignancy in the orbit enough, or do we investigate further? On systemic investigation, we have found that she had hypergammaglobulinemia, an M band, a bone marrow biopsy suggestive of plasma cells and the blast forms as well, and a whole body PET CT scan showed FDG Evett lesion in the right orbit, axial and appendicular skeleton with lytic lesions. So drawing a leaf out of one of the presenters' presentation today on multiple myeloma, yes, I'm here again to present you the same. A multiple myeloma, probably the outward side of the coin. A multiple myeloma is a malignant proliferation of the plasma cells, monoclonal, and is the second most common hematological malignancy. And the orbital presentation might be the initial presentation of a much lurking malignancy like a multiple myeloma. So what do we know about it? Yes, it's an expansion and proliferation of the monoclonal plasma cells and increase in the osteoclastic activity, producing punched out lesions in the axial and appendicular skeleton. And bone pain can be the primary symptom of a patient presenting or already diagnosed with multiple myeloma. We have 65% of such subset of patients who are already diagnosed as multiple myeloma later on presenting with orbital involvement. So we have an isolated entity, a primary extramedullary and multiple myeloma. Funk's classification involves ocular, orbital and neuroophthalmic. Ocular and neuroophthalmic were presented just probably 35-40 minutes ago, and here I am with the orbital manifestation. The management protocol for the same involves treatment with proteasome inhibitors coupled with thalidomide and dexamethasone, and since there is hypercalcemia in this, we give zoledronic acid as well. the patient with us, she completed 8 cycles of target therapy, and on our follow-up visits, she's on a 10-month follow, we followed her for now, 10 months is the latest, and she is doing well. In our case, she was a female, which is multiple myeloma is usually a disease with a higher male preponderance, and she was, the orbit was the initial presentation in her. We investigated her and we found that she had a much lurking malignancy like multiple myeloma. Thank you.